Good morning. I hope you can hear and see me. Alright, so this seems to be working. Today, we look at the demonstration of the urinary bladder. Now we were looking at individual organs. We finished with gastrointestinal system. I will show you the urinary bladder once we take it out and put it into a tray. But ideally, you should first see it in situ when it is inside the abdominal, or rather the pelvic cavity. I've got a specimen which is of the male urinary bladder, but it will be good to see it in both genders because obviously the relationships with other organs is different, with other viscera. The anterior surface is more or less the same in both genders, but the reflection of the peritoneum on the superior surface and the relations of the posterior surface, what is called the fundus or the base of the bladder, are different. I'll try to show you whatever I can on the specimens I've been able to photograph. I actually had another 6 or 7 photos, but I've had internet and system problems, is not able to put it into my PowerPoint, but I'll try to catch up on that in the next class. So this one will probably be a shorter class than usual. But at the same time, please try to correlate with whatever diagrams you have in your atlases, gross anatomy atlases. Please try to acquire one, otherwise try to get one online and try to look at the images of the urinary bladder in situ while it is within the pelvic cavity. So when we take out a specimen of the KUB into a tray, we've already seen the kidneys in situ, right, in the left and right hypochondriac regions, and they were related, the right one to stomach and the left one to the liver and to their respective adrenal glands. This one is an adrenal gland, this one is an adrenal gland, so that's over. And then we saw that at the hilum of each kidney there were structures, and there were ureters, which were most posterior tubes at the hilum, which have a long course and an entire relationship. It's a separate topic in itself, and they both come and join at the posterolateral edges or corners of this pyramid shaped organ, which is called the urinary bladder. Now when you look at the bladder by itself, you'll see that the superior surface is triangular in shape, and it has an apex and a base and 2 lateral edges, beneath which here is a anterolateral surface. Beneath this is the posterior surface. So 2 anterolateral surfaces and one posterior surface, and leading to an edge or an apex in the front. So there is a superior surface, 2 anterolateral, 1 posterior, 4 surfaces. All of them are triangular and they all converge down to the neck of the bladder, or the apex, the neck of the bladder, which is at the bottom of the posterior triangular surface, which is called the base or the fundus. So at that neck is where the urethra begins in both the genders, and the apex is the one which is pointed towards and related to the back of the symphysis pubis. But there is a good amount of potential space called the retropubic space or the pre-vesical space, which separates this bladder from the structures in front of it and allows an area for expansion, for filling of the bladder, because its jaw, it is a muscular sac which is a retainer or container for urine, which is continuously trickling into it from the glomerular filtration of the kidneys, isn't it? So the urine which is transported by the ureter into the bladder stays here till the urethra allows it to go out via the urethral orifice, which there is an internal and an external, and there are sphincters there which allow one of which is autonomic and the other one which is under voluntary control. We saw that this was a constituent of the urogenital diaphragm, the sphincteric action in the urethra. So the emptying of the bladder is a partly automatic and mostly voluntary function in the adult, but in children, small children, before they learn the use of the external sphincter, it is a pretty automatic response. When the bladder is approximately 200 to 300 ml full, the sphincter releases and empties it. So when it is empty, it is a pyramid shaped, kind of pyramid shaped, tough, tight, muscular organ. So when you feel it also, when you see it also, it's a muscular organ. The wall is thick and muscular, but it has a capacity to expand in the adult to up to 1 liter, almost 3 times its capacity, by a stretching and thinning of its wall. And its mucosa also stretches, and the muscle also stretches, and the peritoneum is able to be lifted off the anterior abdominal wall. I'll show you that in the next class, where we will look at the sagittal section and we will see how the peritoneum is reflected from the anterior abdominal wall onto this superior surface. So what we are seeing here is the superior surface onto which the peritoneum reflects, and what you're seeing here is the posterolateral angles into which the ureter enters. Now when the ureter enters, it has to go diagonally through the thickness of the bladder wall to open on the inside, and this diagonal passage of the vesical part of the ureter is by its very design, it is a sphincteric control, not allowing a filling bladder to reflux urine back into the ureter, because that gets pinched shut by the distension of the bladder and the muscles pressing upon the oblique entry of the ureter. Doesn't allow any content of the bladder to reflex upwards back into the kidney. But there are diseases where such reflux happens, and that can lead to certain problems, and which you will see in clinical medicine. But otherwise, if you have a specimen like this, then obviously it is kidneys, ureter, bladder, and 2 adrenals. But we may give you a bladder separate, and then you may have to talk about it. First, you have to identify what it is, and then be able to talk about it. Now, in a male bladder, you will also have attachments of the vas deferens. They are not related to posterolateral angle, but rather to the posterior surface. But in the specimen, it will look like 2 tubes from the edges, angles, and that would help to identify it as a male urinary bladder. So this is the same specimen, but what I had done in the previous thing is tucked in this flap. There's a flap of tissue here. I tucked it in to show you that they have edges, that there are borders. There's an apex and there is an anterolateral border, and there is a superior border. Beneath that there is a posterior surface, and there are anterolateral surfaces. It's just to define for you the shape, and the shiny surface is the peritoneal surface. But actually, when we removed it from the body, we removed it with this continuity. Now this is not an apron which falls forward like greater omentum, but actually this sheet of peritoneum goes up the anterior abdominal wall. So over here in front of it is an anterior abdominal wall. On that this peritoneum was, and the peritoneum was coming down like that and then making a right angle to go onto the, so here the peritoneum was turning to cover this surface, and all this peritoneum was vertical on the anterior abdominal wall. So try to imagine that this shiny sheet is actually vertical on the anterior abdominal wall, and then changes direction and covers the superior surface. In the male bladder, it goes all the way back to the posterior edge, but in the female bladder, it only goes about halfway on the superior surface and then gets reflected onto the anteverted uterus. That we can only appreciate in a sagittal section, which we will see next week. So here, this is just to show you that when the specimen is out in a tray, you'll have to feel it. I'm sorry I can't transmit that online, the feel of it. But you'll see that all this tissue is only one thin layer of peritoneum, whereas from here starts the solid bladder, which is a solid muscular organ. And all this is coverings. This is all pelvic peritoneum going to reflect onto the rectum in the male and sideways onto the pelvic wall in both the genders. So when we lifted it up, we lifted up this anterior edge, which we kept the flap out of the way, and it isn't a full edge like that. Actually, there's only an apex. So this is a bit of a difficult thing. But the point was, I asked the assistant to lift it up so that it would show you this from here to here would have been an anterior edge or border. There's an apex, and there should have been an anterior border. And from here to here is anterolateral, and from here to here is anterolateral surface, left side, right side. But that's not easy to appreciate over here. You'll have to correlate with a diagram, with a label diagram in your book. In your dissector is good, or in an atlas is good. What I wanted to show you is at the bottom of this anterior border and anterolateral surfaces is the neck of the bladder, from where the urethra is supposed to start. But in the male, it is surrounded by this slightly different colored organ, which feels muscular but is not. It's a solid organ. It's the prostate, and this is the prostatic urethra orifice, supposed to be emerging different. Not very clear, I'm afraid. But please remember, see, the prostate is so big, and an empty bladder is not that much bigger than it. Right? So this is probably from an aged specimen, because older men have a slight enlargement of the prostate as a natural process. It's called benign prostatic hypertrophy. All men, as they age beyond the age of 55, 65, 70, they have slightly enlarged prostates, and an empty bladder, which is a collapsed muscular sac. In this case, it's also formalinized, so it's even more condensed looking. It's not that much. The prostate is quite large compared to the bladder, but in actual living conditions, and the bladder can expand to much bigger size. The prostate never changes in size, except as a very, very, very slow growth with age. The point here of this diagram was to show you that you were looking at the superior surface in the previous picture. So when this one, if you take that specimen and lift it up, if you tilt the apex up and remove this, keep this flap out of the way, what you will see is a solid organ at the inferior most end of the anterior border of the bladder, which is the anterior surface of the prostate gland in the male. So if you don't tilt it, but you peel off the peritoneum from the top, it's a pretty muscular wall. It's not very greatly done, but there is a good amount of fat embedded tissue outside of the wall, and the entry of the tubes, 1 tube and 2 tubes, can be seen. This is not so clear. This is 1 and this is 2. I don't know what this is. I think this is still the reflected peritoneum. So this one and this one are the 2 tubes, and this is the anterior, the apex, and the point was to show you the triangular superior surface. This is another specimen, not that one. Now this one was another specimen again, not the one we saw before, because this has been cut away from its ureters and kidneys. So this is a different specimen, just to show you that, to appreciate the superior surface. Now here we've tilted it up again. This was the apex, this was the borders, right, anterolateral borders, and there was supposed to be an anterior border, not very clear in a photograph which is taken from the front. You have taken edge, but the so-called anterior edge is not very clear. Apex usually is, and this from here, all of this is the prostate. Alright, so what this specimen was supposed to do was to show you that there are 2 tubes at the end. This is an end on view. There are 2 tubes attached. This one is clear. One is ureter and one is a vas. So how will you know which is which? The ureter will actually come and stop or enter at the posterolateral corner, the edge of the urinary bladder wall, but the vas will go behind. The vas actually crosses the ureter from front to back, because the vas comes from anterior abdomen. Remember that the vas deferens has to exit from the deep inguinal ring, right? It is coming away from the testicles, testis within the scrotal sac, It is traversing the inguinal canal and it's leaving the anterior-inferior part of the anterior abdominal wall to go towards the pelvis of the bladder. And when it goes to the pelvis of the bladder, the ureter is coming in from the posterior abdominal wall. So, let's say in my body, this is posterior, this is anterior. So the ureters are coming down like this and curving forward to enter into the backside of the bladder. The vas is coming from the front, going back like this, right? So it will have to cross this forward coming ureter and it will go behind the posterior surface of the bladder and be related to the seminal vesicles, together with which it will form the ejaculatory duct, and then it will enter into the prostate. It has to open into the prostatic urethra. Now all that is not very clear in our dissected specimens which we have in the tub, but when you all come back, we will do a demonstration of it to show you the organs and the relations of the posterior surface of the bladder, which is called the base or the fundus of the bladder. This was just to show you that if you see two tubes attached to a specimen on either side, that is most likely to be the male urinary bladder. In the female, there will not be a vas. There will definitely be ureters, but there will not be a vas on either side. We usually don't dissect out a female urinary bladder and put it on a tray. I don't have one. We show you the female urinary bladder in a sagittal section of the pelvis, which I'll show you next week. But remember this as the way to identify. Now we are looking at it from the back. This is one tube, this is the other. This, you can't make out the two different tubes, but they're there. This is a posterior surface. Okay, there is no peritoneum here. The shiny thing belongs to the front. You ignore that. So this fleshy mass, actually we should have dissected it out neatly. We would have seen seminal vesicles. You're not able to see the prostate separately, but the posterior surface is a triangular base or fundus of the urinary bladder. This we put it upside down. The whole bladder, we just put it down. It is lying on its superior surface and its neck is up. Right? We put it down and it's up. So the structures which are related to its superior surface are all down on the tray, and you are looking at it upside down just to show you the exit of the prostatic urethra. Now if this is male, if there's a prostate, then it must be male. If it is male, the first part of the urethra is prostatic, so it is going from bladder into prostate and then out of prostate, and when it comes out of the prostate, it will enter into the urogenital diaphragm, right, and become the membranous part of the urethra because it goes through the perineal membrane. And once it comes out of that, then it enters into the penis and becomes a penile urethra. So we know that a urethra has three parts. We don't ever get to see a urethra as a specimen. We only see it as a relationship or an opening or something in some other part. In a sagittal section also, in the female, it's a very, very short tube. It's only a 4 centimeter tube. It comes out of the bladder. There is no prostate. It pierces the perineal membrane and then it's out. It's in the female introitus, right? It opens in the vestibule of the female perineum. So the point here was just to show you that this whole thing is the prostate and this is the exit point. So if you're confused with your specimen, look at its firm to hard part and look for an aperture, and if you see it, then this is likely to be prostate with urethra, in which case this is the urinary bladder with all its other structures. Now because these specimens are so basic, they have not been dissected out very cleanly, it's difficult for me to demonstrate to you as per the textbook that this is this, this is that. But right now, if you have a book, if you have a dissector or a manual or anything with you, please correlate what are the things which you are supposed to identify. In a practical, all you're required to do is identify the parts and talk about them. Even if it's not looking very triangular or very pyramidal, that's how you describe it. You describe the four surfaces, you describe the borders, you describe its edges or angles, and you describe its related organs, whatever it may be, as they are in the tree. If you do that correctly, then the next step they'll ask you, okay, so what is a blood supply and what is a nerve supply, and all that you should be able to talk about it. If you're answering well about the prostate, they will ask you about the prostatic venous plexus, and they will ask you about the possible morbidities, diseases which can happen, which is benign prostatic hypertrophy. Also, your patient can have carcinoma of prostate, in which case that the nodule, which is cancerous, will be very, very hard to feel, and there will be ways of doing investigations to confirm that that is a carcinoma or not. But in life and in health, the way the prostate relates to the bladder is that its median lobe, it's supposed to have 5 lobes, so its middle lobe is projecting a little upward into the bladder where the urethra enters it. So that can only be appreciated if you open it up. Now, this picture was just to, he's holding only the prostate, the urethra is in the center of it, the urethral aperture. So this hard portion at the neck of the bladder is easy to palpate and therefore easy to identify. So remember to look for by feel for the prostate. If you find the prostate and then you position the whole thing so that that hard part is down, and then you have an apex in front and a triangular thing and these attachments at the posterolateral angles, then you're oriented to the way the urinary bladder is supposed to be. Here what we've done is we've opened it up. So let me just go on. Okay, here if you take an incision from apex towards posterolateral corner, apex towards posterolateral angle, this V-shaped flap can be opened out like that, right? Because it's cut like this, it can be opened out like that to reveal to you the bladder wall, right, and its mucosa, what is inside. So that is what we're trying to see over here. So we took, this was the apex, he's holding on to the apex, this is the apex, right? So from apex to posterolateral end, one cut was given, another cut was given, and then this split apex is now lifted up to reveal to you the bladder mucosa. This is surprisingly corrugated, wavy looking wall. Bladder is supposed to be a very smooth walled sac, right? Now this is in the empty state. In the collapsed empty state, the bladder mucosa is loosely folded upon itself and very, very much distended. One of the identified features in histology, that you have a very wavy bladder mucosa. In a filled state, that mucosa is able to stretch. It's one of the features of transitional epithelium also, that it has, its structure is such that the cells can be pretty chubby and when they are all collapsed together, or they have the capacity to stretch and thin out without losing the very tight intercellular junctions that are required for protection against the corrosive excretory product, which is urine. So in a gross anatomy specimen, you will expect to see a mucosa which is of a corrugated or a folded, don't call it corrugated, just a wavy folded nature. The wall is pretty thick, and when you feel it, the muscle of the wall can be felt, and that we know is called the detrusor. The smooth muscle of the bladder wall is called the detrusor. That you can see or describe, or you can point out that deep to the mucosa, that whole wall is thick detrusor muscle. Then you pulled it back, you pulled up the whole, this is the whole superior surface of the bladder. If you pull it back, you see the trigone. You see an area on the inside which is consisting of the internal orifices of the left and right ureters and the internal orifice or the beginning of the urethra. So this area is supposed to be called the trigone. In this picture, I don't know if you can appreciate, compared to the rest of the wrinkly mucosa, this portion is a little smooth. I don't know, can't make out. This one looks more smooth, right? But the portion between urethra, ureter, that portion is called the trigone. It is easily identifiable in the specimen. My camera didn't get this too well. And it looks smooth, it looks different from the rest of the bladder mucosa that you see. And its identifying or distinguishing feature is that it does not have a submucosa. So the mucosa is directly applied on the musculature, on the muscle of the wall. This is important, and it is also a pointer to the fact that the two parts of the bladder have developed separately. So they might expect you to know this in the viva, that the trigone of the bladder develops from mesoderm, whereas the rest of the bladder develops from endoderm. This is an important differentiator, and that's explains the reason why the histology is also different, and you will see later the nerve supply is also different. The musculature, how it is supplied by nerves, is also different. Because nerve supply is different, the functions of the two portions of the bladder will also be slightly different. That you must please revise under autonomic control of the urinary bladder. That's a physiology thing. So here we have the anatomical area called the trigone, which is nothing but the triangular area of mucosa delineated at the angles by the urethral orifice and the two uretary orifices. This is a little better, at least the openings are a little clearer. These are actually ureteric are slit-like openings, and this is supposed to be a V-shaped opening. It has a V kind of a look. You make out? Not really. Okay. And in a fresh specimen, in a younger man or probably just a more fresh specimen, this area, the area just behind, will be slightly bulging, because that is where the middle lobe of the prostate is kind of bulging up into the neck of the bladder, right? And that name to that little bulge is called the uvula vesicae. Like you have a uvula at the back of the throat. This is a little uvula hardly there, which is a bulging up of the median lobe of the prostate at the internal urethral orifice at the neck of the bladder. And that is the one which grows, and because of that, if it is growing as part of BPH, benign prostatic hypertrophy, it can reduce the diameter of the internal urethral orifice, or it can press on the internal urethral orifice, giving rise to a retention of urine, inability to void completely. So a patient, an older man, will come and complain that I'm not able to empty my bladder. I get the feeling to go and void. I void some, but I don't feel as if I've emptied the bladder. Then I come away, and again within an hour, half an hour, again I have to go. So this incomplete voiding or urinary retention because of prostatic hypertrophy is a very, very common symptom, and the anatomical basis of it is this median lobe or uvula vesica becoming more prominent because of growth of prostate in old age. This will only happen if it's the median lobe which is growing. If any of the other four lobes of the prostate are growing, this symptom will not happen, because that's on the outside. That does not impinge the urethra. Only that part of the prostate which houses the urethra. If anything happens to it, you'll get urinary symptoms, which is good because you can pick it up early. The patient will have some complaint and he'll come to you. Otherwise, if there is a growth in some other portion of the prostate, patient won't even come to you till it becomes pretty much huge or pretty difficult, or it has already involved some critical or vital structures. So from an anatomy point of view and from your practical point of view, what you need to know is, in an open section of the bladder, you notice the folds, the corrugated appearance of the inside mucosa of the bladder, and you notice and describe the trigone, and you'll be able to tell the 2 points of differentiation between trigone and the rest of the bladder wall. So I think that finishes the specimens which I have, but I had 2-3 other specimens which look like this, but they're more brown in color. So like the whole bladder part which I had was more brown, the whole thing, and it was less tough or tight. It was looser. So when you opened it also, it looked much smoother. So I wanted to show you both variables, because if you look at them immediately, you may not be able to make out that they are the same organ. So there is a slight normal variation between how that organ will look depending on which cadaver we got it from. But I think if you remember this for the time being, that this is alright. The gross morphology, the parts, the names, the terminologies, all of it, and the relations. In the female, you will not have seminal vesicles and vas. The posterior cervical bladder is immediately related to the cervix of the uterus and to the upper quarter of the vaginal wall, what is called the fornices of the vagina. But that is again appreciated best in a sagittal section, where you see pubic symphysis in front, then the bladder immediately behind it, then the uterus cervix behind it, and then the rectum behind it. We'll do that in the next class. For today, I think I'll end here only. With the specimens available, this is the best I could do. I'm sorry, this I don't know how else to conduct a practical demonstration class. If I did it as a video also, I don't think I'd be able to do much better, because what you need to get is the feel. Looking at it may or may not give you much information. But yes, you look for the attachments of the vas and the ureters. Besides, if you definitely in your exam specimen, it's much nicer, easier, much more like a textbook than this. This is what we had in the buckets, because we were waiting for your batch to do the dissection and deliver the organs, and then we would have demonstrated to you. But that didn't happen. So this is from some things we have had from before. So just remember these points. External features as well as internal features. I don't think I've forgotten anything. Revise it. If there are any doubts, please send it to us by SMS. And I'll see you all next week with sagittal section of the female pelvis.